Hi everyone, welcome. Welcome to today's virtual morning report. So my name is Bettina. I am a medical graduate from the Philippines and I'm so excited to co-discuss with Rabih today. And I think we have an amazing case. Um, we have Francisco here to present his case for us today.
Yeah,
So
hi everyone. So I'm Francisco. I'm a medical graduate from Portugal. I'm super excited to be here, and I really must start by thanking Kirtan and Omaima. They have really helped me quite a lot to put this case together, and without them, I wouldn't be able to present it, I'm sure. And yeah, I'm thrilled, and I hope you enjoy. And yeah, let's go.
Francisco, it's a huge day today for two reasons. The first is it's Bettina's first ever case discussion, and we're really excited for her, and we're going to be egging her on the whole time. But also because I don't know if people know that you were on VMR a long time ago, and this is not your first appearance. You're making your comeback, and
Yeah.
what a great way to come back with a case that we're really grateful for and excited to learn
It
from today.
is.
Thank you
Yeah,
for putting it together.
actually, my first VMR was the Brazilians VMR back in January.
I
And
remember.
I usually like to say that I've been adopted by the Brazilian community here in the US because there are
Yeah.
so few Portuguese doctors
I know.
around. I know only a handful of them. So yeah, the Brazilians, the Latinos, they have really made me one of them, and I'm so grateful for that.
Amazing. Yeah, that's so cool. I want to give a shout out to two other Brazilians. One is Deborah, who passed her very hard internal medicine exam. Please give her some love in the chat. And then another
Yeah.
Brazilian, Amanda Francisco. I don't know if you know Amanda, but she is, along with Omaima, the leader of the case review committee.
Yeah, I
And
know, I know.
yeah, she's incredible. She's right there, and her and Omaima have done so much to make sure that your experience with the case review goes well. So thank you for that spontaneous plug for it, and I hope anybody listening will be inspired to submit their case. It's easy. You just send a small version of your case to our email, which is theclinicalproblemsolvers@gmail.com, and just write in the subject case review. We haven't had any UTIs. We haven't had any cellulitis on VMR. So please, if you have a UTI or cellulitis, please submit it. It'll be the most rare diagnosis we've seen on VMR, and we need more of that. So Francisco, I guess I'm saying I hope you have a simple case for us. You may not, because I know the three of you, Omaima and Kirtan, are probably going to stretch us today. So why don't we go ahead and get started?
No, I think you'll do fine. Yeah. So I hope you
Good.
enjoy. I hope you enjoy. So yeah, should I start?
Yes, please.
Okay, so let's move to the first aliquot. So we have a 28-year-old gentleman with fever, shortness of breath, and productive cough for the past 3 years. Should I move on? Do you want to? For the past 3 days, sorry, not years. Yeah.
I think this is a great place to stop. Bettina, what are your initial thoughts?
okay, so with fever, shortness of breath, and productive cough, I think my mind just goes straight to an infectious etiology and something, of course, that would involve the pulmonary system, basically. Um, with a 28-year-old male, I would not, well, at least with an acute presentation in a 28-year-old male, I would probably put the like neoplastic or any chronic inflammatory disease at the bottom of my list right now. So right now, I'm just more focused on something that's infectious in the patient, or maybe an environmental exposure that triggered these symptoms in our patient. So, how about you, Ravi?
I completely agree. I think we have to assume that acute fever is infectious until proven otherwise. And I love how you're taking the shortness of breath and cough and saying it's probably in the lungs. That combination is very suggestive of a respiratory tract infection. I'm curious, Bettina, what, is there anything about this symptom complex that surprises you?
For me, I guess in a presentation of 3 days, maybe I wouldn't necessarily think that shortness of breath would come out so acutely. I would think that shortness of breath would probably present in a patient that's probably in a longer presentation or later on in the presentation. I would expect fever and productive cough, but not much on the shortness of breath. That tells me that there's something that's serious already that's going on in the patient that must be addressed acutely.
Exactly right. Think about all the 28-year-old people that you are likely to see in the internal medicine world who get an infection. The vast majority of them get an upper respiratory tract infection, which by definition cannot involve shortness of breath. So here, the shortness of breath strongly suggests a lower respiratory tract involvement, which in extremes of age is easily attributable to the immunological dysfunction that happens at a young age or an older age. This person is between that and is already very unusual for somebody in their 20s to develop a lower respiratory tract infection. So what does that do immediately? It changes your initial evaluation, which you otherwise wouldn't do in an older person or a younger person, because you do not need anything addition except their age to explain their lower respiratory tract infection. So I'm curious, Bettina, how might this influence your HPI? What other questions would you ask the patient simply based on the fact that it's unusual for a young person to presumably get a lower respiratory tract infection?
One thing that I would want to know about this patient is if he has had this same symptoms before, if it has been a recurrent, like for example, if it is a pneumonia, if the patient has a recurrent pneumonia, or he's very prone to other types of infection that could probably tell me that the patient might have like something like immunodeficiencies or cystic fibrosis, or I would also want to check, well, aside from that, any other past medical history that could explain why the patient is already predisposed to such a serious presentation at the very start.
I completely agree. The idea that this person is vulnerable to this process now might mean that they had a high risk of developing it earlier and earlier and earlier. And I think it's really important to get, if you're worried about immunodeficiency, to understand what the past looked like. And I think the past will be very, very important. As a general framework, if you're invoking the suspicion of immunodeficiency, it's helpful to stratify it into two different types. Structural immunodeficiency is basically a mechanical immunological dysfunction, which can occur because of an obstructive lesion, impaired ciliary clearance, destructive airway damage, or the patient can have a systemic immunodeficiency as a result of the actual immune system itself. So if you take all comers with pulmonary infections, the vast majority of people have a local structural immunodeficiency like COPD and dysfunctional airways, or cystic fibrosis and bronchiectasis. So I think we don't know he has an immunodeficiency, but we have to dive much deeper in him simply because of his age. Change his age to 88, and then this becomes a very common concern with pneumonia. Make it 28, and you're exactly right. We really have to wonder why this is happening to him at such a great age. All righty. Francisco, tell us more, please.
Yeah, right on the spot. Great comments. And I was also looking at the chat, and they were saying they were adding very nice topics that I hope to address. And let's see the HPI and the review of systems. So the patient presented with fever, chills, fatigue, shortness of breath, and productive cough with thick yellow-green sputum. I would like to remind it's 3 days. He has also noticed some blood streaks in his sputum over the past few days. So now he hasn't urinated for the past 6 hours. He has chronic rhinosinusitis for many years, but denied having any similar symptoms like the present presentation before. Do you want me to say the review of systems? Do you want to let me know?
Well, since Bettina anticipated this,
Yeah.
now you have a little bit of a lead, Bettina. You thought to ask it. What do you think about the information you just got?
Well, first of all, the chronic rhinosinusitis jumped at me. Like, it kind of hints to me that there's some sort of possible immunodeficiency in the patient. Usually, sinopulmonary infections are common in those with, for example, B cell deficiencies. And then I would also want to explore that the patient had blood-streaked sputum. I'm not sure if that already constitutes hemoptysis, but I guess if it is, I would think that there's probably an invasive process happening in the pulmonary parenchyma or something in the vascular that could be a problem in the patient. How about you, Rabih?
I think that's superb. It is so cool, Bettina, for you to see how something you thought of to ask him, you asked and you got a positive result. And I think you really should commend yourself for that. And I think as you're learning, you'll then, the next stage of your growth will be to realize to be careful about anything that you elicit in this way, because let me explain. The vast majority of people who have sinusitis have chronic, non-infectious sinusitis. They have chronic sinus symptoms forever. And so here, the fact that we picked that up is only helpful because we were hunting for a clue to suggest immunodeficiency. However, the vast majority of patients with sinus complaints have non-infectious irritative sinusitis. Why is he not like the vast majority? He's not the vast majority because he is now developing evidence of lung disease. So what does chronic sinusitis mean in all comers? It means just a pain and an annoyance for them. But he is not all comers. And it's just for this reason that he is removing himself from the base rate of disease by declaring that he is different than most other people by the fact that he is showing up as a 28-year-old with lung disease. So I completely agree with you. Now we have to say this is a person with chronic sinusitis who's developing lung disease. And the mistake that we can easily make is to assume that his lungs are the only part that's diseased. As we continue to progress in our journey to first understand the problem and then try to solve it, there is a tendency to prematurely pretend like the problem is just sinuses and lungs and ignore any subtle clues of liver or renal involvement. So where am I at? I'm actively resisting the temptation to lump this as just a immunodeficiency involving the either a local or systemic immunodeficiency because we don't know how his system is affected, and that's going to be very, very important. So kudos to you for knowing that the past is going to be helpful here. And I think it is tremendously helpful, but only helpful here because of his unique presentation. And I'm really curious to see what other information we get.
Oh my gosh, can I just say
Yeah.
I'm sorry, I completely forgot about the decreased urine output. It's something that we
Yeah.
also have to take into consideration.
Yes.
So I mean, we can also consider that the patient might be developing an AKI, so we have to be sensitive about that and see like the possible etiologies like pre-renal, intrinsic, and post-renal acute kidney injury.
Superb. Bettina, if you were to be honest, in your experience, how often has a history of reduced urine output truly correlated to objective reduction in urine output? What do you think? What's your instinct on the correlation?
It's low.
Yeah. If you ask any internal medicine intern or a surgery intern or a medical student on the wards what their urine output is, they will tell you it is very low, but their kidneys are great. So here, again, the same concept comes up. Real life, you would completely ignore that sentence, and as you should, but you should not ignore it and forget to order a creatinine. It's just to order a creatinine. So in real life, yeah, in real life, that is much more likely noise than it is signal. Because I'll tell you, I think my urine output is abysmal today, probably very, very poor, but I'm going to work on it right now while we do the VMR. All right, Francisco, tell us more, please.
Yeah, amazing comments. You're so methodic and some nice humor there too. So the review of systems was otherwise negative for syncope, chest pain, nosebleeds, headaches. The patient also denied changes in weight, night sweats, dysuria, dribbling, or hematuria. Nausea, vomiting, and diarrhea were also not present. In terms of medication, he only assumes using intranasal corticosteroids for chronic nasal congestion. And probably lastly, just to say the social history, he's married. He was born in rural Portugal and immigrated to a suburban city area 10 years ago. He recently came back from a trip to Central America. He denied any exposure to animals, seafood, insect bites, tick bites, mosquito bites, or recreational drug use. He has a 5-pack year smoking history. Yeah, you can start discussing.
Tina, what do you think?
Uh, to be honest with you, for me, I think based on the given history, there's not much that would add to my differentials at the moment. Maybe just the ROS that helps me kind of like remove some systems that might be affected. But like something that would probably like help me narrow it down more. I think maybe I would like to just focus also more on the PE findings.
I absolutely love it. I think that's superb. As the exam is coming your way, part of getting the exam is to try to anticipate some things and to also to specifically look at things that based on your story. So what parts of the exam are you most inclined to hear about and or do if you were taking care of this patient? What do you think?
Well, for me, well, first of all, I want to check on the vitals of the patient, given
Yeah.
that it was a really serious presentation of his symptoms. I would want to make sure that he's not, for example, in septic shock or something that we would need to address immediately, even before we finish the history of the patient. And then I would also want to focus my PE, of course, on the pulmonary exam, a cardiovascular exam, and make sure that the abdomen is not also affected, and also see the extremities, because I know that some conditions that present with like sinopulmonary, it's not just the immunodeficiencies, but it can also appear as like a vasculitis or some other things that can help us narrow down our differentials.
I absolutely love it. Thank you. That's awesome. All right, Francisco, tell us more, please.
Yeah, great. Let's move to the physical examination. So the patient was appearing unwell and in severe respiratory distress. Uh, in terms of his vitals, he was febrile at 38.5 degrees Celsius, tachycardic at 122 beats per minute, tachypneic at 36 breaths per minute, and his blood pressure was on the lower side at 95 by 65 over 65. He was saturating at 88% on 3 liters of oxygen and 30% VO2. So respiratory examination, he had bilateral crackles and bronchi on auscultation. He had elevated pulse rate and hyperdynamic pulses, normal S1 and S2, and no murmurs. No skin, no in the skin, no rashes, clubbing, or signs of thrombosis. No synovitis or signs of arthritis. The abdomen was clear, and yeah, the pitting 1+ edema on the inferior extremities. Yeah.
An amazing exam. Tina, what are you thinking?
For me, I would get started on fluids and address the oxygenation of the patient. So that's the first thing that I would do. And then, well, I think it's something we expected already in the pulmonary exam, the crackles and rhonchi. I just wanted to clarify if it's all over or just like at the basal,
Yeah,
all
yeah.
over, right? So I guess my first steps would be to stabilize the patient, and then also try to get a chest X-ray and maybe ABG. How about you, Rabih?
Yeah, no, I think I love what you're thinking. You need to stabilize this patient, and it's hard to think about anything else except that right now. And I think the first thing is to recognize that this person is heading towards hypoxemic respiratory failure. So the escalation will be first through nasal cannula, then through masks, either a non-rebreather or a Venturi mask. And then you have a decision to make in people. Do you use BiPAP or do you use high flow nasal cannula? The only indications for BiPAP over high flow nasal cannula in hypoxemic respiratory failure is when a patient has high suspicion for heart failure. Main reason. So we should ask ourselves as we start to support this patient, if he were to need more oxygen, which I think he does at 88% setting, 36%, do we ask for high flow nasal cannula, invoking all the mechanisms except heart failure? Or are we worried enough about heart failure that we should try to take advantage of the positive pressure that BiPAP would afford? So I think that's the first decision we should make, Bettina. So what do you think? Do you think that you're confident enough he has heart failure to give him BiPAP, or would you escalate to high flow nasal cannula? What do you think?
I think I'm not so sure about this part of the
Yeah.
management. I haven't actually dealt with a patient like this, honestly, but maybe I would want to go with the BiPAP route because I think our patient is progressing really quickly, and maybe there's something that I think it's a little bit serious that we have to address immediately in our patient. But I'm really not sure about this one.
Yeah, I really admire your just how high level your conversation is, but also admitting and acknowledging the situations where you haven't experienced and you have opportunity to grow. So look at this case. I mean, it's impossible not to worry, at least to some degree, about heart failure. You have crackles, you have edema, you have hypoxemia, you have hypotension and tachycardia. In many ways, this is heart failure screaming at you. And the question is there anything else that argues against it? And I think that there's some subtle clues that it might not be heart failure. The first is that the patient is febrile. Most heart failure is non-inflammatory in nature. And so when you see fever in a syndrome, it's very unlikely for it to be heart failure alone. It could certainly be that the patient has an infection worsening their underlying heart failure, or the patient has an inflammatory cardiac disease like endocarditis. But that possibility is rare. The reason I would avoid BiPAP in this situation is a small possibility that he has right-sided pressure overload. He has some hypoxemic process that's driving right-sided heart failure secondary to the lung issue, and that might that excessive intrathoracic pressure might cause cardiovascular collapse. So my advice from this conversation is the use of BiPAP in hypoxemic respiratory failure should only be limited to slam dunk causes of heart failure causing hypoxemia. If there's any ambiguity, I would highly recommend that you use high flow nasal cannula. And here, even though heart failure is not ruled out, it's a very compatible case with it, should we get more data. But the risks involved with BiPAP in a patient who is cardiovascularly tenuous, tachycardic, and hypotensive, and those risks are overruling the right side of the circulation, would push me to use high flow nasal cannula. And I'm curious, now that we've talked about that, how are you thinking about the rest of the exam?
For me, it makes me want to explore more the pulmonary pathology. Like I said before, I would get the chest X-ray and an ABG, especially with the impending respiratory failure in the patient. And then it's interesting that I don't think there were no rashes in the patient, which normally, with purpura, that's something that I would consider as vasculitis. I'm also seeing that the patient has edema, so I'm not sure if the patient has some sort of overload happening in the process, or some blockage that leads to the edema. But yeah, those are my
Yeah.
initial thoughts on this.
Yeah, I think as you were thinking earlier, now we can be much more confident that this person doesn't just have a sinus and lung issue. He has edema, and the edema will either map onto a cardiac issue, a renal issue, or a liver issue. And I think the liver issue shows up on exam. I think it's almost impossible to have hepatic causes of edema without jaundice or ascites. So it's down to the kidneys and down to the heart. And I think that that'll be very, very hard to tease out. This case is slam dunk for heart failure, except for the inflammation. It's much more common for inflammatory diseases to affect the kidney. And so hence all the itises, glomerulonephritis, interstitial nephritis. So the most worrisome hypothesis might be that he has a kidney issue and has diffuse alveolar hemorrhage, causing his hypoxemic respiratory failure. So I think the real practical situation here is to recognize that one test that you might completely ignore becomes the most important diagnostic test here, which is his urinalysis. Because the UA, if it's showing hematuria and proteinuria here, will be really, really key. In most patients, it won't. And this case will be a severe infection of the lungs. But if you aren't priming yourself to look at the urinalysis in a patient like this, you'll completely miss the possibility of DAH. Because if you see kidney bleeding, you'll then infer that the patient has lung bleeding as well. But the decision we have, Bettina, is we have a febrile patient who's tachycardic and hypotensive. So I'm curious, what antibiotics would you be thinking about giving him while we wait for this data? Because he's already too sick for us not to give him antibiotics. What would cross your mind for empiric antibiotics for him?
For me, I would probably give ceftriaxone and piptazo. I think those are. I'm not sure if we should start also vancomycin for possible MRSA, or I'm not, or I don't know if metronidazole will also be given for if it's an anaerobic infection.
Yeah.
Yeah.
So there's amazing guidelines that you can look up on IDMP. It's a great website for empiric antibiotic choices. And here what you would be treating is community-acquired pneumonia in the community. And the treatment for most patients with community-acquired pneumonia is ceftriaxone and doxycycline. In patients who are sick enough to go to the ICU, we recommend adding vancomycin for MRSA and switching doxycycline to azithromycin for the possibility of Legionella. So in many places in the United States, this patient would get vancomycin for MRSA, ceftriaxone for strep pneumo, and azithromycin for Legionella. The rate of severe gram-negative rod infections is not high enough in normal community people that we would not usually use a broad gram-negative organism. The exceptions are when if we discover that he has structural lung disease. So if on our X-ray he has signs of bronchiectasis, we might change our minds. But empirically, meaning with what we know now, he would probably get vancomycin, ceftriaxone, or azithromycin. All right, Francisco, tell us more, please.
Yeah, great. I really enjoyed how the discussion here switched from focusing only on the diagnosis to you who rapidly recognize the importance of the management here, which was very nice. So, okay. A chest X-ray revealed dilated airways, mucus plugging, hyperinflation in normal left-sided cardiac silhouette. The patient was started in eye-flow nasal cannula and fluids. Blood cultures were sent to the lab, and empiric treatment was started with vancomycin, cefepime, and levofloxacin. In terms of labs, you had a sodium of 130, a potassium of 3, chloride of 90, bicarb of 34, hemoglobin of 11.5, white blood cells 22,000, with 85% neutrophils, 10% bands. Just let them write. And creatinine 1.5, BUN of 40, glucose of 200, and albumin of 2.5. Yeah. then I can tell you the rest later.
Okay, thank you, Francisco. Sorry. Okay, so just looking at our labs, what I can see is that the patient has a slightly elevated creatinine at 1.5 and an elevated BUN that can support the possible kidney involvement in our patient. And then WBCs of 22,000 can hint us to possible infectious etiology or just inflammatory origin. And then for the chest X-ray, for me, I think it could tell us about possible bronchiectasis in our patient that is caused, maybe it's caused by mucus plugging, or maybe it's caused by like having recurrent infections that eventually led to the dilation of the airways. So yeah, those are my initial thoughts. How about you, Rabih?
Absolutely. Yeah, no, absolutely superb. I completely agree with you. You know, we were worried about a lower respiratory tract infection and really invoking the value of imaging of the lower respiratory tract. And we have a surprising finding, and that he has a bronchiectasis, a structural form of of lung disease. And I think it should be emphasized that about 40% of bronchiectasis is idiopathic without a specific cause. So while we try in most of our patients, a large number of them don't have a specific cause. And you're right that the majority of them have it because of recurrent infections from an immunodeficiency, with IgA deficiency and common variable immunodeficiency and chronic granulomatous disease, those three being the most common causes of immunodeficiency causing bronchiectasis. But in a large fraction of patients, you have local structural disease that is maybe macroscopic, like a mass, but macroscopic diseases cause focal bronchiectasis. In a patient with diffuse bronchiectasis, the structural diseases are usually microscopic, with impaired ciliary motility being one of them from Cartagener syndrome, or the sputum being too thick to excrete, such as that occurs from cystic fibrosis. And then there's all sorts of, there's the possibility that a chronic infection in the lungs can do this with non-tuberculous mycobacteria, namely Mycobacterium avium intracellularly being the most common one. And there are a lot of smattering of random disorders that can do this, including Williams syndrome and yellow nail syndrome, both of which we've actually had on VMR before. So how do you make progress? I think the simplest things are to test for the immunoglobulins in this patient, the IgA and the common variable immunodeficiency. But given the base rate of cystic fibrosis, it's something that we have to think about. So the immunodeficiencies are relatively simple to think about and test about. A simple blood test for immunoglobulins, at least to start. So I'm curious, Bettina, how would you go about considering for a moment analysis for cystic fibrosis? What would cross your mind to do?
I remember that to diagnose cystic fibrosis, it's usually like genetic testing for the CFTR gene. Then you can also do the sweat chloride levels, although I'm not so sure which one you do first or which one's the gold standard.
Absolutely excellent. So you're right. The next step in terms of significant progress would be to do chloride sweat testing, and the idea is that patients with cystic fibrosis have skin chloride wasting. So their chloride is usually very high, over 60 in the skin. Between 30 and 60 is indeterminate, and less than 30 makes cystic fibrosis less likely. And in a patient with a positive or indeterminate test, you then follow up with genetic testing. But there are some subtle clues that you can pick up about non-pulmonary manifestations of cystic fibrosis that will cue you in. Do you have a mental model of the non-pulmonary manifestations that might help here?
I'm not so sure with the patient's presentation, but I remember the other manifestations of cystic fibrosis would be pancreatic insufficiency.
Excellent.
So if the patient would be presenting with steatorrhea or like malabsorption of the fat-soluble vitamins. And then sometimes there's also I think it's meconium ileus. I'm not so sure.
That's right, exactly right. So with that now in mind, take another look at the labs. Does anything else strike you as a possibility of maybe relating to an extraintestinal manifestation? It's a hard question, but you said pancreas. So can you connect anything in the labs to the pancreas here?
Um, wait, sorry. Oh yeah, sorry. It's the glucose.
Yeah,
I missed the
but
glucose earlier.
Bettina, we're so used to taking care of older patients. A glucose of 200 in a 68-year-old is like every single day of our existence. It's so hard to remember that this person is 28.
Yeah.
28, you should not have a glucose this high.
Right.
And I'll say the albumin is a clue too. He's only been sick for 3 days. An albumin to go from 4 to 2.5 in 3 days is unusual. It signifies a little bit of chronicity here and makes me wonder whether he's having malabsorption or nutritional issues. Yeah, how do we make progress? I think we have to focus on the acute stuff. The hypothesis that he has bronchiectasis, which would be confirmed by CT, should change our antibiotics. So we initially said vancomycin, ceftriaxone, azithromycin, but now he has structural lung disease. So we should have broad gram-negative coverage, and I commend Francisco and his team for changing ceftriaxone to cefepime. That's very important in this case because of organisms like Burkholderia, Cepaceae, and Pseudomonas, which are common in patients with bronchiectasis. And I think immunoglobulin analysis, chloride sweat testing are the next step in general. And then if that's negative, you can do advanced ciliary testing to look for ciliary dyskinesia. And some small things you can do are look at the nails to make sure you're not sitting on a simple, on a physical exam diagnosis of Yellow nail syndrome, which we've had on the end before. All right, Francisco, tell us more, please.
Great, amazing. I also saw a comment here about someone asking the rural area of Portugal the patient came from, and I don't remember quite well, but I'll get to that probably at the end. So I don't know if you, Austin, if you have been to Portugal, but nice question there. And so moving forward, blood gas analyses revealed a pH of 7.2, a PCO2 of 88, a PO2 of 70, and the bicarbonate I already gave you. Urine analyses showed muddy brown casts only. And as the patient's condition kept worsening, he was mechanically intubated and started on norepinephrine, and tracheal aspirates were sent to the lab.
Thank you, Francisco. So for me, so with the ABG findings of 7.2 pH and then PCO2, that's very, very high. I think that further confirms that the patient could be in respiratory failure, and thus the patient was intubated. So that's great. And then in urinalysis showed muddy brown casts, if I recall correctly. I think that would point us to possible acute tubular necrosis, which could be ischemic or due to toxins. So yeah.
Yeah, I completely agree. The UA here was to make sure that you're not sitting on a case of ANCA-associated vasculitis, and the lack of proteinuria and hematuria is great. There are not many ANCA-associated vasculitis that show up as bronchiectasis, but MPA or microscopic polyangiitis does. And so that was an important test to rule out. And yeah, I think the tracheal aspirates are really important. In many patients with pulmonary infections, there's little to no value in sending their sputum or tracheal cultures. But in patients who are in the ICU, who are critically ill, those have enough diagnostic value. And in patients with bronchiectasis, they have diagnostic value. In other patients, the probability of contaminant from oral flora is high enough that sputum cultures are not recommended in most patients. But here, because the patient has both indications, bronchiectasis and a critical illness. All right, Francisco, tell us more, please.
Yeah, okay. So the sweat chloride test was obtained due to, sorry. Oh my God. Wait, let's go back. Respiratory viral panel.
Tina, you're on the right track. Or he's completely fooling us. We'll see.
Yeah.
I think he just made us more nervous than anything. I don't think he disproved anything.
There may be a plot twist. Let's go. So respiratory viral panel for influenza, parainfluenza, RSV, SARS-CoV-2 was negative. Chest CT revealed airway dilatation, lack of tapering towards the periphery, compatible with bronchiectasis, predominantly on the upper lobes, peribronchial consolidation, mucoid impactation, a few enlarged lymph nodes were also described, and tracheal aspirates grew Pseudomonas aeruginosa. Should I say the sweat test, or do you want to?
No, it's okay. No, no. Oh my gosh, no, it's all good. Bettina, what do you? I will share with you that there's maybe not much to advance the knowledge so far, but I'm curious what your reflections are with this data.
Oh, I'm just glad that the antibiotics that were given to the patient
Yeah,
covered
yes.
Pseudomonas.
Yeah. Maybe it's a good time just to practice real quick, in maybe a minute or two. What is your short list of antibiotics that help you with Pseudomonas? Do you have a list of anti-Pseudomonal antibodies? This is a good thing to review.
Well, I remember Piptazo would cover Pseudomonas. A lot of the higher generation cephalosporins, well, cefepime is one. I'm not sure about the others, but I think there's another one that's higher generation cephalosporin.
Yeah, that's
Sorry,
pretty
I
good.
don't remember the rest.
No, oh my God. It sounds like it sounds like if you were on an island, you would already know 3 options. This is more than you need, honestly. But yes, Piptazo is the most famous one. Cefepime is a close second. Ceftazidime is a nice cephalosporin.
There.
Ceftaroline is another one. As is, and then you go into the carbapenems. And it's important to know that ertapenem does not cover Pseudomonas, and meropenem and imipenem do. Aminoglycosides are a great Pseudomonal coverage. And then the only oral option, period, is the quinolones. So there are many IV options: imipenem, meropenem, ceftaroline, ceftazidime, piperacillin, tazobactam, cefepime. You'll never struggle. But when you're trying to treat Pseudomonas orally is when your options are very limited with the quinolones, ciprofloxacin, moxifloxacin, and levofloxacin. I'll say that there's one important clue about this CT, which is the location of bronchiectasis affords some clues, as does its change with inspiration and expiration. So the CT actually can guide the workup. In patients with cystic fibrosis, they have upper lobe predominant bronchiectasis. And in fact, it's actually not just any upper lobe, it's right upper lobe predominant. So in real life, I would scrutinize the CT to see if the right is more affected than the left. It's a powerful clue for cystic fibrosis. And there are other imaging-based clues. So if you see mucoid impaction, that should make you think of allergic bronchopulmonary aspergillosis, ABPA, but the patient doesn't have eosinophilia. And there are other clues, including airway collapse, which are a feature of Williams disease. So long story short, you don't have to remember any of that, but to know that the imaging, beyond just the words bronchiectasis, the radiologist can use non-bronchoectatic clues, including location, distribution, other features, to help you with your DDX. And here, the upper lobe predominance is giving you even more momentum to test for cystic fibrosis. All righty, tell us more, Francisco, please.
Okay, now you all know what's coming next, right? Okay, so sweat chloride test was obtained due to bronchiectasis and Pseudomonas aeruginosa growth, and it returned 45. He has been going to infertility clinic since the patient and the wife have not been able to conceive a child. A previous sperm analysis had revealed a zoospermia.
What do you think, Bettina?
Yeah, so I remember that I think male infertility is also one of the extrapulmonary manifestations of cystic fibrosis. So that's but we can also, well, it's cystic fibrosis, I think, in our patient. And then important here is to address the bronchiectasis and address the infection in the patient, continue the antibiotics, and give therapy for airway clearance, and then of course nutritional support, because the patient may have signs of pancreatic insufficiency, and we should have continuous monitoring in our patient.
Yeah. Yeah, I love how you're managing this case. It's absolutely superb. Um, just to comment on the diagnostic aspects in addition to your management, the sweat chloride test is technically indeterminate. And because your pretest probability is not low, you would then follow up with two options. You can do genetic testing, or you can actually do nasal potential. Basically, there's a nasal test that outperforms the chloride sweat test. Um, and so you might ask, well, what does the infertility afford? Well, the absence of vas deferens is actually a feature of cystic fibrosis, and that's why patients with cystic fibrosis can get infertility. I actually don't know if we image the vas, excuse me, if we can image the vas deferens, but the other possibility, of course, that we've been toying with all along is ciliary dysfunction. The full form of ciliary dysfunction causing situs inversus is Cartesian syndrome, but only a minority of people with ciliary dysfunction have the full-blown spectrum. So, Bettina, you and I cannot say that this person doesn't have ciliary dysfunction simply because he doesn't have situs inversus. So I think the testing for ciliary dysfunction is actually pretty complicated. You start off by measuring inhaled nitric oxide because that's a product of ciliary function release. That's a place to start. And the ultimate test is histopathological analysis on electron microscopy. It's a very advanced testing. So I've never done this in real life, but it seems pretty costly. So what I would probably do is just recognize that base rate should guide us here. Cystic fibrosis is orders of magnitude more common than ciliary dysfunction. So I would probably, if I'm trying to be cost effective, recognizing, as you just said, that it doesn't change our immediate management, to start off by closing the book on cystic fibrosis before opening the book on ciliary dysfunction. That's how I would approach it. Any questions about any of that, Bettina?
Uh, I think there's a lot of things that I would read up on after the
Yeah.
session.
Yeah, I love that. I love the honesty here. There's so much to read on. And I think let's just stick with what we know. We know this person has bronchiectasis. The pathway is immunodeficiency or ciliary issues or cystic fibrosis. That's the pathway in most people. But let's recognize also that many of these cases end with idiopathic, many of them. Here, the probability is much less likely because of the extra pulmonary manifestations this patient has, which is not a feature of idiopathic bronchiectasis. All right, Francisco, tell us more, please.
So yeah, since sweat tests were indeterminate and given the difficulty of obtaining samples correctly in this severe patient, genetic testing was pursued. Genetic analysis revealed a pathogenic CFTR mutation. The patient was started, the long story short, of course, the patient recovered, it was stabilized, and it was started on tezacaftor, ivacaftor, chest physiotherapy, nebulized Dornas alpha, and is being considered for chronic prevention of exacerbations with inhaled tobramycin. So final diagnosis, you got it right. You mentioned it actually right on the first aliquot. You were spot on, did a great job, and yeah, you can say the last discussion.
Francisco, this was an absolutely amazing case presentation. It really was. I think your decision to pause at the first aliquot to allow us to have a very rich conversation before revealing the rhinosinusitis is a great example of how to present cases to allow us to discover clues before you give them. And Bettina latched onto that and asked for that rather than being given for it. And that moment is so symbolic of the rest of the hour where both of you are just shining so bright that I think any program that you're applying for would be lucky to have you, honestly. And we certainly are lucky to have you here. So thank you for doing that. Bettina, how was it to discuss your first case?
Oh my gosh. I was so nervous the whole time. I think personally my reflection is that I think from the get-go, I kind of had some tunnel vision. I was just too focused on the pulmonary. I mean, I guess it worked out in the end, but I know that there will be cases in the future, patients in the future where I have to take on a broader approach to things and make sure that I'm not missing anything with the symptoms, with the PE, and even in the labs. I missed the glucose, but it's a really, really interesting case. Thank you so much, Francisco. I love how you presented it. And I love how each aliquot really built on the previous one, and how at the very end we see the whole clinical picture, and we really can say at the end that, oh, this is really a diagnosis, this is how it unfolded. And I really loved it. So thank you so much for the case.
No, I'm the one that has to thank you. You were really the star here, and I really wouldn't be able to make it without Kirtan and Umaima. They also did a great job, not only orienting me, but also making sure that everything was going fine and encouraging me and motivating me. So yeah, I can't thank them enough. And yeah, this was a very interesting case. Actually, in Portugal, we have it's quite common, let's say, for rare disease, cystic fibrosis. So the antibiotic coverage was taking that into consideration right from the start. We also must pay attention to the sweat test in a patient with critical illness. Probably if you had done the sweat test in other conditions, it would probably be really positive. And yeah, there's not much to add. There are very few patients with cystic fibrosis that present after 18 years old, so that's also something I would like to highlight. And of course, you just made it. It's mostly a clinical reasoning, but I really loved it how fast you were on it, thinking about management and then diagnostics. Even though then the diagnostic was the fundamental part and the main differential diagnosis with Carter-Jenner syndrome. So yeah, it was a great case, a great experience for me, and I'll surely be back.
Yeah, I know you've surrounded yourself with the Brazilian community members in Mayo, and we hope that you virtually surround yourself with Bettina and her colleagues here on VMR. It will be a thrill to have you here. Thank you so much for joining us. I know you're very busy researching away. Thank you. All right, Mario.
You
It's
so
not
much.
Mario, it's Marino today. Guys, you should all know that Marino is taking VMR by the storm. You will see him so much in July. I was looking at the future whiteboard and scribing and teaching points, and it's basically a flying solo show from Marino. So I hope your July adventures are going well, my friend. Thank you for teaching points today. Take it away, please.
They're going very well. So thank you
Good,
very
good.
much, Francisco, for the amazing case. And Rabih and Bettina, you did an amazing job today. So let's go with the teaching points. So from the get-go in this patient, we got a really concerning shift complaint of fever, shortness of breath, and productive cough, which very rapidly suggested us that we were present in a case of respiratory pathology. And the shortness of breath really helped us to localize it on the lower respiratory tract instead of the upper respiratory tract. So also this patient had fever. So the fever, we consider it to be fever is considered to be infection until proven otherwise. And oh boy, we were correct in this case. So in the case of this patient, that he was a 28-year-old male with no concerning history as to date, his age was really concerning to present to the clinic with a lower respiratory infection. So we had to think about many things that can cause him infection. In this case, we had to rule out or think about immunosuppression, cystic fibrosis, bronchiectasis, and if this presents in an older patient with no relevant history, we should think about COPD. So in the case of this patient, we had to look for signs and symptoms of associated pathology. And in the case of this patient, we found that he had chronic rhinosinusitis that can further guide us to think towards other etiologies such as cystic fibrosis. Also, the physical exam in this patient really guided us to the severity of the disease that he was presenting. So from the get-go, we did see that he had a really high temperature, a low BP, a high respiratory rate, and was deciding very quickly. So maybe sometimes we have to shift our focus instead of diagnosing and go straight with management. Later, we saw that this patient was intubated, and basically we were trying to save his life instead of trying to look for diagnostic clues. So after patient was stabilized, we decided to get the team decided to get other tests. So the urinalysis is very good in this patient to narrow down our possible diagnostic clues. In this case, he only presented with muddy brown casts and suggesting that he had a very high creatinine. Probably he was experiencing some sort of kidney dysfunction, but this helped us to rule out that he doesn't have a vasculitis. In this patient, he had a community acquired pneumonia by the guidelines. So if we were to try empirically treat it, the first therapy that we should think about was ceftriaxone and vancomycin, remembering that we can always de-escalate later or change the therapy after cultures are back. So when we got the chest X-ray for this patient, it gave us an amazing clue. So the patient had dilated airways, mucus plugging, and hyperinflation, which is highly suggestive of bronchiectasis. In 40% of cases of bronchiectasis, it is idiopathic, but we have to think about possible etiologies for bronchiectasis in such a young patient as this was. So first came to mind common variable immunodeficiency, chronic granulomatous disease, and IgA deficiency, but these three etiologies cause recurrent infections, and that means that it will cause a focal bronchiectasis rather than a diffuse bronchiectasis, which was the one that this patient had. So this patient with diffuse bronchiectasis, we have to think about other etiologies such as cystic fibrosis and ciliary dyskinesia, such as Cartanegger syndrome. So in this patient, after we have like this clinical picture, what was the best next step that we could go next with him? So basically, parting from the last aliquot that I just mentioned, immunoglobulins and sweat chloride tests were the best tests that we could get for him. And he got a sweat chloride test of 45, which is inconclusive. If we get more than 60, we know that CF is very likely, but as it was inconclusive, we had to get further testing. And in this case, it was genetic testing, which really showed us the disease that he had. And also something that Bettina said that was really good to know is that in this patient that was hyperventilating and had a PCO2 of 88, basically when you get a PCO2 and you're hyperventilating, it should be low. But in this patient, it was really high. So we have to think that we're in a picture of impending respiratory failure and intubate quickly the patient and give him respiratory support. And that's what I have for you today, friends.
Absolutely amazing. I feel a little bit bad because we just had we had somebody just join us now. I imagine the times were a little bit off. You missed Marino's outstanding teaching performance by 1 second. Thank you so much, Marino. It was a great overview and recap of the case. Thank you, Francisco, for your wonderful presence in this amazing case. And Bettina, very impressive discussion, latching on to early clues and demonstrating, I think, what we admire in Melissa's community is humility and growth mindset. That combo of, I don't really know what this is, but I can't wait. I have so many questions. I don't have anyone to ask you now. I will admire that a lot and respect that a lot. Anyway, we'll hope to see you all on VMR soon. Just as an FYI, the time for tomorrow's RLR is a little bit unusual. So if you are one of those people who is on VMR autopilot, tomorrow's RLR is 2 hours earlier than it usually is at 7 a.m. Pacific. So just as a heads up. Alrighty, y'all. Take care. Bye now.
It was a pleasure. Thank you so much, guys.
Thank you, Francisco.
Yeah, enjoy. Bye.
Thank you.